So welcome to the roundtable strategies to increase adherence. I think it will be an exciting session because we have a panel of experts, an amazing panel of experts for us today. We can start with the first speaker. So we are pleased to have with us today Dr. Sarah Dean. Dr. Dean has a dual background as a physiotherapist and a psychologist. So we are really happy to have her here today. She is an associate professor at the University of Exeter in England. As a former international athlete, she has a thorough understanding of motivation and efforts. She recently participated in a roundtable organized by the physiotherapists at the ICS about adherence to treatment. So our presentation will allow us to better understand the importance of motivation.
Bonjour, and thank you for inviting me to come and speak today and to visit your beautiful city of Montreal. My talk is focused on strategies to promote adherence and in particular understanding motivation. And as an outline for my talk, I'd like to provide a few background points and key terms, dispel some myths, some common myths about non-adherence, look at some of the psychological models and theories that we use to understand adherence and motivation, and in particular focus on behaviour change techniques. And then looking at how these strategies can be put into practice with a view particularly of mentioning the OPAL study, which is a randomised trial that's currently going on in the UK. And then at the end of my talk, I'll try and bring all that together. Some key terms. Traditionally, we've used the term compliance. So this is the patient being told what to do. They are a passive recipient of the care, and if they don't do the treatment, it's their fault. We blame the patient. This term has been somewhat superseded by the term adherence. Much more about the patient and the therapist or the clinician agreeing what should be done, not blaming the patient. Some people have found that term also problematic, and so a new term, concordance, was decided upon. However, this tends to only be used in the world of medication adherence. It's more about the therapeutic alliance and shared decision-making, and it hasn't been universally adopted. So my recommendation is we use the term adherence. On this slide, I also want to identify the issue of intentional versus unintentional non-adherence, and to distinguish between these two concepts. So unintentional non-adherence means that the patient would like to adhere, but for something has got in the way. Perhaps they've actually just forgotten what to do. And yesterday we heard about the mobile phone app for helping women do their pelvic floor muscle training. And that would be an excellent way to help the people who are unintentionally non-adherent and need some reminders. But there are other people who are intentionally non-adherent. They've chosen not to adhere. They've chosen not to take up the treatment. And so a mobile phone app to remind them might not be so useful. When I'm talking about treatment adherence, we tend to think of it as a new behaviour, a new health behaviour is needed. They need to do this treatment. And so behaviour change is required. And in order to change behaviour, you need the motivation and you need the resources. So within the person, the internal factors are a strong intention to change and the necessary skills. And I'll talk more about that in a minute. There may also be extrinsic factors coming into play. So whether perhaps an environmental constraint, perhaps they can't afford the treatment that's being proposed. In my work, I tend to be focused on exercise adherence, and so I've put up a very general definition of therapeutic exercise as opposed to physical activity. And I'd also like to remind people about the different phases of exercise adherence. There's that initial problem of getting people on board and starting. Then there's the crucial aspect of getting them to create a routine. And these are the sorts of things that might happen during a supervised treatment program. But then once they leave the clinic, there's an element of needing to maintain that routine and also manage any relapses. And I'll talk more about those in a minute. We know that exercise adherence and adherence to treatment generally is problematic, and there's a whole range of figures that can be used as examples for this. But the most important point is that patients are missing out. Either they're not just doing enough of a treatment or they're not doing it at all. But often people will know what to do or what they should be doing. It doesn't mean they're actually doing it. There's a big gap between knowing and doing. Initial uptake may be quite good, but it doesn't translate into a routine. And then people have a break from their routine and don't resume it again. But I'd like to dispel some myths about adherence and motivation. There is no adherent personality out there. There are some people who are more conscientious about their healthcare and doing the right things, but there isn't a personality factor that says this person is always adherent and this person will always be non-adherent. Similarly, adherence is not an all or nothing effect. Some people will be partially adherent, and that may be sufficient. Some people may be adherent to one treatment, but not to another, or they might be adherent at one point in their lives, but not at another point. Similarly, non-adherence is not just about giving people more education. Good quality information, yes, but more and more and more education is not going to necessarily solve the problem. When it comes to motivating people to adhere, some strategies have been used where we try to frighten our patients into taking up the treatment. Some of the consequences might be so dire that they are definitely going to do it because you've pointed out that this is a devastating endpoint if they don't do their treatment. So with pelvic floor muscle training, the idea that you might end up being a leaky and smelly old woman. But these sorts of fear strategies tend not to work very well. Occasionally they'll work for a particular individual at a particular time point in their lives, but as a general campaign, they don't work. And we know that from the anti-smoking literature and other areas of healthcare. There are many theories and models to try and explain and help us understand motivation and adherence, but sadly, no one single theory explains it all. And in our State of the Science series of papers, Doreen McClurg and colleagues have looked at quite a number of theories in pelvic floor muscle training. We looked at 12, and while some of them are quite good and useful and helpful, no one theory says it all. So in the world of behavioural medicine, some researchers led by Susan Mickey in the UK have come up with a set of strategies or techniques, individual techniques, and they've created a classification system or a taxonomy of these techniques. And at the moment, the taxonomy has 93 techniques in there. You don't need to know them all, and they're clustered into groups, and here are some examples. So as health professionals, you are credible sources of information, and that can be a really useful strategy. Goal setting is another cluster of behaviour change techniques, and in particular one called behavioural contract, which I'll explain a bit in a minute. But also biofeedback is another strategy, and I'll talk again about that too. This is a model that I think is quite helpful because it is straightforward. It's been updated and it's become more complex, but I like this version because of its simplicity. And you can see that information is in there because you need good quality information. People need motivation, and people need the skills to carry out what the treatment is. And if all those things are coming together, then you're going to get the changes in health behaviour that you want. So in the OPAL study, we're attempting to optimise pelvic floor muscle training to achieve long-term benefits and adherence in the longer term. And we're using a lot of the behaviour change techniques to try and make the motivational strategies work. So in particular, the OPAL study, which is run out of Glasgow with our colleagues Suzanne Hagen and Doreen McClurg and others, and they particularly asks the question, does biofeedback optimise adherence? But we're also using other behaviour change techniques within the protocol. So in terms of information, we want to check the quality of the information that the patient has, but also check for any misinformation. Goal setting features quite strongly. We've recently completed a brand new Cochrane review on goal setting in rehabilitation, and there is some evidence that it improves quality of life outcomes. So goal setting is a good thing to be doing, and I'm sure a lot of you already do this with your patients. And you need to have goals around the behaviour, the actual exercise program, but you also need goals around the outcome that you want for your patient, i.e. less leakage. If you're setting goals, you also need action plans, so very clear instructions about when and how to do the exercises. So for example, first thing in the morning when I go to the bathroom, I know that I'm going to be doing 6 sets of 10 repetitions of whatever the exercise that I want the patient to do. And here you might then ask the patient to verbally replay back to you what it is that they've agreed to do, and then sign on the document that says what their goals are. This is the behavioural contract. It is a powerful strategy for increasing adherence. And then I'm sure all of you who've done goal setting will naturally also monitor progress, feedback, review, problem solve any issues that are arising. Another element of motivation and skills is self-efficacy. And certainly we would recommend self-efficacy as a good strategy for increasing adherence to pelvic floor muscle training. Self-efficacy is focused around skill mastery. So do the women know the correct technique of contracting their pelvic floor? Perhaps biofeedback comes into play here. But self-efficacy is also about noticing success. It's about you persuading and praising your patients to do a good job with their exercises. It's also about noticing physiological state. So typically in a physical activity program, you need people to be aroused and up and ready to go and do their exercises. But with pelvic floor muscle training, it might be the other way around. Women need to be quiet and calm and able to be focused on what they're doing and not overly anxious, because that might get in the way of them doing their exercises. This is where biofeedback comes in. So biofeedback gives you the really good information about whether you've got the right skill. It gives that visual, auditory, and sensory feedback on your performance, the accuracy of that technique. It provides an objective record, and for some, it's quite engaging, isn't it? You can see the graph going up and down as you contract your muscles. There's even games that you can play with some of the devices. However, it may not be universally acceptable for everybody to use these, particularly in a home setting. And certainly in the OPAL study, that will be one of the things we're looking at. Does biofeedback enhance and increase the intensity of the program and get better adherence for our patients? And is it acceptable for them to use it? Ongoing motivation and longer-term adherence is also an issue. Have you agreed longer-term plans for your patients? Do they know how to self-manage? Do they have a regime that is for progressing their exercises? But do they have a regime that's also about maintenance of exercise? Do they have a relapse management strategy? And this is where something called if-then rules come into play. So if I've had a break from my exercise program or my treatment, perhaps I've been unwell or perhaps I've been on holiday, but if I've had this break, then on Monday when I get back, I'm going to be doing my exercises again. So if this happens, then I will do this. The other thing is to reassure patients that relapses are normal. It happens, and we all have phases when we don't adhere to our treatment. So that relapse management strategy becomes very important. Have you skilled up the patient to have all these things that they need to self-manage their problem, self-monitor, review their progress, and of course know when to get more help if necessary. So to summarise, beware the non-adherence myths. Don't label your patients for the wrong reasons. Check the quality of your patient's knowledge and understanding about their treatment and the condition and the treatment that you are proposing. Promote motivation and skills, some examples I've given you today. As specialists, you've been doing this for years. You're probably really good at it. You're probably naturally doing it anyway. All I'm saying is use these techniques explicitly. Document the fact that you're using them. Review them, reflect on them, decide which ones are going to be helpful for you to use. And finally, agree those longer-term plans so that people know how to carry on once they've left your care. Thank you.
So the room is now open for questions. So if you have any question, you go at the microphone, identify yourself, your name, your country, and then you ask your question.
Hello, very good talk. My name is Ligia Rivera, and I'm from the U.S. I was wondering, in my work with consumers, we've debated whether to establish a routine, a behavior. Do you have any information about daily practice versus intermittent practice versus weekly practice? Any information about that would be greatly appreciated.
Okay, great question. You know, my answer is going to be, it depends. And the reason I say that is because for any one individual, one type of routine will work better for another than for another. I'll give an example. We did some interviews with women in New Zealand, and there was one lady who was very clear. She needed to do her exercises every day, and that was her regime. That's what made her feel she was doing what she needed to do. There was another lady who was fine about the fact that if she did the regular exercises 3 or 4 times a week, she was confident that that was sufficient for her. And if she had a day or 2 off, she didn't feel bad about that. So I think it is really about tailoring to the individual and having that conversation with them. Because for some women, if they have a day off, they think they've failed. And so can you reassure them that a day off isn't a failure? And I think perhaps the backup there is to say more about what we understand about exercise science. And we know that if you have 2 or 3 days off your training program, you're not really going to go backwards too much. But if you have 2 or 3 weeks off your program, then you might have to go back and start building back up again. So it's that sort of understanding. If women can feel confident that they're not going to lose all the good work that they've done by having a little break, that's good. And then what is it that they need to just keep it topped up? So it's all of those sorts of bits of information, that quality information that might help.
We may have time for one last question.
Hello, I'm Vanessa Farrow from Canada. I'm a physical therapist. I practice a lot with male incontinence and male pain. Can you share your input as to differences between male and females? Clinically, I find that males are highly motivated, they're good, and they always want to do more than the female patients. So
that's a really interesting observation, yeah. So it's, again, perhaps reflecting on what will work best for them. And there is a small set of the population will be what we call over-adherent, and providing they're not doing themselves any harm, I wouldn't necessarily worry about that. But I think you just need to be reassuring them that if they aren't perfect, that is also okay, and that perhaps 80% adherence may be good enough, and give them the reassurance about what's the window that they can manoeuvre in for their exercise program. I personally haven't done a lot of research on gender differences. So in terms of other strategies, I defer to people who've got more experience in that area.
Thank you very much, Dr. Dean.
Okay, thank you.